Welcome everyone. I was just waiting on the pings slowing down there a wee bit because we seem to have quite a lot still joining us there. My name is Des McCart. I'm part of Healthcare Improvement Scotland, and welcome today to our session on ethical commissioning in relation to people who require services around about drug and alcohol services. Great to have everybody here. I think we've got quite a lot joined on. We are recording today's session. You'll see that that's up on the bottom of the slide there. We are recording the session, recognising that people do have incredibly busy lives and jobs. So it allows people to either go back to this that have joined today, or indeed those who have not been able to join today to come in and join at a later point. So going to just get started. It may well be that there's a few more that might still join as we go along. Just by way of a welcome introduction, as I said, so I'm Des McCart, Senior Programme Manager with Community Engagement and Transformational Change at HIS. Ridiculously long title, but co-hosting today is Dee Fraser, who's the CEO of IRIS. And Dee, I just wonder if you want to just come in and say hi to folks, because Dee led the work that's commissioned here, so it's a brilliant piece of research. For those who have already read it, I'm sure you'll agree. Just to introduce Dee, who's going to share the detail of it in a wee while. Do you want to come in a wee second?
Magic. Thanks, Des, and welcome everyone. We're really delighted so many people are interested in this piece of research. I'm going to, as Des says, just going to spend a bit of time running through the findings very much from our perspective of what we learned about alcohol and drug service, purchasing, planning and delivery perspective, less about commissioning, because colleagues at HIS will have a look at that, and hopefully there's some time for Q&A, and you can get in touch with me afterwards if you have detailed questions that we maybe didn't get to during the session, but looking forward to it.
Thanks, Dee. So just before we get fully started, just recognising that the nature of the work being covered today, and we do have some of the more detailed kind of content from colleagues working out there in the field, working directly with people. So recognising regularly work with, it's a very emotive context. There might be content today that includes, I find, some personal experience across alcohol and drugs, which may be triggering. So it's important that you look after yourselves, and if you need to take a break, then absolutely do so. It is only an hour and a half session, so we don't have any planned breaks, so that's all the more important. The chat will be using for questions, but if there are anything more personal questions relating to work, then please do use the email address there, his.transformationalchange@nhs.scot. That will go up in the chat as well, so you'll be able to contact us if there's anything from this that you wanted to pick up with us more directly. So before we're really getting into the meat of this, just wanted to sense where people are starting from. So a couple of questions, and they'll come up as a poll, and it'll be kind of rating low to high, just to get a sense of how would you rate your current understanding of supporting people. Oops, I've just lost it. Thank you. How would you rate your current understanding of supporting people with who use drugs and alcohol? So we'll just give a minute or so for that question, and then we'll move on to the next one. Hopefully you can engage the poll. Okay, that's brilliant. I can see the responses coming in. That's brilliant. We have a large audience today, so there's 90 already and 150 signed up. So we know that we're reaching a lot of people here. So it's just to get a sense of what are people's kind of starting points of understanding the issues that we discussed today. So that's ticking up nicely. I think you should be able to navigate between the polls, and certainly the link is there in the chat if you ever want to go back to it. Do you want to move on to the next question? So second one is, how would you rate your current understanding of commissioning? We're kind of bringing two worlds together here in terms of the world of services that support people with drug and alcohol needs, related needs, and commissioning world. And this is a theme that will come up throughout it, just the extent to which those two worlds perhaps haven't been as aligned as we might have thought. Okay, so again, I think we're getting a fair amount of response there. Okay, thanks. As I say, you'll be able to go back into them. The links are there, so you can, if you've not managed to complete them, you can go back in. So, without further ado, we'll move on to the agenda for today then. So what we want to cover is basically that. What is commissioning, ethical commissioning? And I'll give you a wee talk through just some very rudiments, very kind of rudiment elements of commissioning and ethical commissioning. The main content then coming in sections 2 and 3, where Dee will talk through the findings from the research itself, which gives a broad overview, gives some of the kind of key thematic insights that came through from that work, and then hearing from some of the local areas that were involved. So we hear from Verius Hopkins, who's lead officer protecting people at Dundee City, John Holleran, strategic lead at North Lanarkshire, and Michelle Duncan, strategic planning manager at Lanarkshire and Stirling. So being able to hear some more detail from each of them in terms of the work in those areas, and there'll be time for Q&A and amongst all this. Not loads of time, which is why we're saying that if you wanted to follow up with questions afterwards, then by all means do that. But there will be some time to explore the kind of key points that come through from that work. Okay, so starting off, what is commissioning, ethical commissioning? I'm unfortunately one of those who's learned in the dark arts of commissioning, and it was interesting when the notion of ethical commissioning came up. Perhaps denoted that what was done before wasn't ethical, which was quite an interesting point to raise. But it's much more than that. So what I want to do is just talk through commissioning itself, what it is, and to some extent what it isn't, and then to think about so why we introduced the concept of ethical commissioning. So commissioning is an umbrella term covering planning, delivery, resourcing, and evaluation of a range and diversity of services and supports designed to meet the needs of a given area population. So it's that whole spectrum, and it is a pivot point between the strategic planning and the procurement, from the thinking about and planning to the actions of doing and making sure that services are there for people. And commissioning is that linchpin in between, so it spreads into both those worlds, and it's a world which is often used in different contexts, which presents an issue. You may be thinking of a conversation about the same aspects of commissioning, and then realise that actually we're talking about different aspects of it. So that's one of the elements that we want to kind of think through here, is that what's commissioning understood to be within the context here. And when it comes to it then, in reality, good commissioning considers the decisions about what we call make or buy. So that thing is this something that we do as a public sector direct provision? So is it something that's done within NHS boards, within local authorities, or is it something that we're seeking partners to support in doing? So it already begins to see some of the complexity in there, that it's not all about procurement, which is often one of the challenges that I've seen about commissioning, that it's a synonym for procurement, but actually it's a bit that comes much more into that planning stage and understanding what it is we want to do in the first place. Is that something that the public sector already do or should be doing? Or is it something that you're looking for the support of partners who may be better placed to do? And it's a term which became more prevalent as in the integration journey. So however many years back it is now, when the Integration of Public Bodies Act came into place, one of the key requirements in there was a strategic commissioning plan, and therein was a whole load of discussions about, was it a strategic plan, was it a commissioning plan, which goes back to that continuum. So what it was really about describing the relationship between that integrated authorities have, IJBs, integrated joint boards have, with the NHS boards and local authorities. So that what you're getting there is something that brings together, it's a push and pull in terms of making decisions about that commissioning, what it is that each of those bodies do and what it is that each of those bodies may want to commission externally. And good practice in commissioning across health and social care, I mean, it's been discussed and researched in many forums. Dee and I have, as I say, that unfortunate history of being along this journey for quite a long time, and it has been named many different things. It's been collaborative commissioning, it's been commissioning for outcomes, it's been trust-based commissioning, it's been community-based commissioning. Those are not 5 different things. Those are broadly the same thing, and it's just that focus of having some principles at the heart of it, which really mean that you're driven by what matters most to people. And you can see that in collaboration and commissioning for outcomes and trust. It's much more about the people end of it, rather than it being the procurement end of buying, and the term being widgets and digits is the kind of the challenge that was there, that's something which developed more to buy pens and pencils than it was to think about how you ensure that there are care and support services. And that's why these terms came through. And as we moved into the terminology of ethical commissioning, what's really helpful about it is it's built on 9 principles. So it's not prescriptive of saying ethical commissioning is exactly this, but it's based on a set of principles. And what's happening just now is across the country, we're still working through what do those principles look like when they're put into action. So the 9 principles, first ones really are right at the front, are around people. So people, person-led care and support, and human rights-based approach. So having them at the heart of what you're doing in terms of commissioning practice, full of involvement of people with lived experience, making sure that's in the design and the continuous checking in and the quality management, that those things are there right at the beginning and at the heart of it. And then thinking into some of the practice around it, especially in terms of staffing, as well, outcome focused practice, high quality of care and support, and fair work practices, so that the people working within health and social care have got good conditions that respect their role within that, and that those are, when we talked earlier about collaboration, that's the thing about people being alongside people, which is fundamentally what care and support is about. And then into the system elements of it, thinking about financial transparency, sustainable pricing and commercial viability, and then shared accountability. And some of those, I think, especially the financial stuff, very often were more of the driver in the past, that we had a limited public purse, and therefore how do we do as much as we can with that limited resource? And that really led conversations. And as you can see here, that's been turned around to have people at the start of the focus, and making sure that, well, yes, we do need to work within financial budgets, it starts with what matters most to people. So that gives you a wee bit of a sense of just what we mean by commissioning. Sorry, and the last one is climate and circular economy. Sorry, that's another part of it. It's just recognising, especially as we see some of the challenges that the world faces now, as those are important that we have them in as part of the ethics. So I'm going to pass over to Dee, who's going to talk you through the research itself. If that's what commissioning is, and that's what ethical commissioning is, what does that look like when it comes into the world of services to support people with drug and alcohol-related needs? Dee.
Thanks, Des. Sorry, I'm attempting to take control. Bear with me a second. That seems to be us. Great. As Des explained, Iris was commissioned to do a piece of work on behalf of Healthcare Improvement Scotland to look at really those principles and ethical commissioning as a kind of broader context, specifically within alcohol and drugs partnerships. And it's actually a companion piece of research to a broader piece of work by Blake Stevenson, which looks at social care as a whole. And this is interesting for us at Iris, because our specialism, as Des has already outed me as a commissioning geek, is very much in commissioning, is in the sort of functional aspects of how you plan, purchase, and deliver care and support in an area. But today I'm going to try to focus on the findings as it relates to service rather than sort of the technical aspects of commissioning, because that's been covered really well already. So, what did we do? So very briefly about the study, and this is really just so that you can hold the findings and weigh them up appropriately as we go through the conversation. So our piece of work was done by myself and my colleague, Dr. Louise Bowen, and her contact details are at the end of the presentation if you want to get in touch. So what we did was a small scale, fairly exploratory study looking at the the way that ethical commissioning is expressed within alcohol and drugs partnerships, whether it is or not, and actually fundamentally whether people, particularly ADP coordinators, actually see themselves as commissioners or if they see their role as something a bit different and as commissioning something that happens elsewhere in the system. So to do this, we did your classic three-stage study that anyone on this call who's a researcher will recognise. We did a literature review, both of the formal and grey literature, and a look at ADP plans just to see kind of what does commissioning look like within that? What words are people using? What kind of concerns are arising from that? Then we did a series of semi-structured interviews to give us a sense of breadth of ideas across Scotland. So we spoke to service providers, ADP coordinators, policymakers, some of whom are on this call, I think, people working in strategic planning, and organisations that represent people with lived and living experience. And I think on reflection, like all researchers, if we'd had a bit more time, it would have been great to maybe speak directly to those groups. But those organisations, I'd like to note my thanks to them for giving us their time and their perspectives on behalf of the people they work with, support and represent. We then looked at 3 case studies, which was an in-depth look at 3 areas and how they approach the challenges of commissioning, ethical commissioning in alcohol and drug services. This was Perth and Kinross, Stirling and Clackmannanshire, and North Ayrshire. I'm going to speak thematically about the case studies today because we have practitioners speaking after me to give you more of the depth of the direct work. But the case studies are available at the end of the research report for the detail. So from the method to the context. I know everyone here is probably very aware of the context, but we have 2 contexts operating in the research finding. The context of alcohol and drugs partnerships and the very sort of unique structures that many of you on this call work within, and also the context of ethical commissioning, which is sort of initially conceptualized as a social care kind of sectoral approach, and how that then transfers over or doesn't to this very unique context that these services operate in. So as you know, ADPs lead the development and delivery of whole system strategies aimed at reducing the use of and harm from alcohol and drugs in their areas. These are multidisciplinary, non-statutory partnerships. It would be fair to say that all respondents described them as not having necessarily a huge amount of positional authority, being very much a systems leadership position, and they are operating in a very complex policy environment with a notably centralised vision, direction and priority setting when you contrast it with other areas of public service. It's quite a targeted funding environment, and it is a standards and outputs driven system largely. So that's a very particular operating environment that influences how commissioning is expressed quite substantially. Then, of course, there's the commissioning context. As I said, this is the ADP context is substantially shaped by central policy drivers and targeting of funding and standard-driven, what I would describe as standard-driven commissioning from the centre. Social care commissioning, from which a lot of the thinking around ethical commissioning in its current form comes, probably has a slightly higher degree of freedom to respond to local priorities and needs, but is not without its own challenges, as we all know, around resourcing, fragmentation, increasing demand, and innovation in services that will fit the changing needs of populations. So basically, we saw a high degree of variation in how alcohol and drugs partnerships approached commissionings, and very much a high degree of variation in how ADP coordinators viewed themselves as commissioners and as not commissioners, and the importance of that within their work and within the system. So what were our findings? So I'm just going to do this as fairly broadly because I've got about 15 minutes. So I may not be doing justice to the depth of the responses we got from the people we spoke to. But overall, our findings were a high complexity and a highly complicated environment that this particular service area is. So when I say that, I mean complexity in the systems way. So there's lots of interdependencies. There's quite a few unexpected outcomes or emergent qualities from what you would think would be very logical interventions, maybe not giving what we expected them to do. There's also a high degree of complicatedness. So there's a lot of systems, strategies, priorities, fragmentation of funding, different directions, different standards. So there's quite a lot of moving parts in the system. And then there is a degree of complexity around the multidisciplinary nature of the work, the very different perspectives around the various tables involved in ADP work, and a sort of fundamental I put it here as contested interventions, and I think those of you who work in the sector will be familiar with this. There is quite a high degree of agreement on where we want to be in terms of the services we want to provide and the lives we want to support for people who are affected by alcohol and drugs. But there is a high degree of it's quite a contested field and people want different things from the system and think there are different answers that should be resourced in order to drive that. So a key aspect within that was residential rehab, for example, with some parts of the system seeing that as very much the answer, and others reflecting that they would like to see different use of that resource to reach people in a different way in a more community orientated approach. So that was just one example of this very fairly contested field. I'd be interested in the Q&A if this reflects people's experience on the ground. Just the last few, lag in responsiveness, fragilities and strength. The other really strong finding that came through was an issue to do with data. So bear with me because I know that always sounds a very geeky and a bit of a boring thing to say, but what we found, and we found this from multiple respondents, didn't matter where they stood in the system, was the changes on the ground where people were working directly with people or ADP coordinators were quite close to that, were moving quite rapidly. So this might be a degree of rapidity in changing substance use patterns. It might be a degree of rapidity in where people wanted to get support, so where people were actually turning up for services as opposed to where notionally the priority said services should be, and that this was moving quite quickly, but the feedback of information back to the priority setting centrally by government and by ministers was fairly slow. So this then moved slowly, priorities then moved slowly. So there was a disconnect between what was being measured and what was being driven and what was being seen on the ground. So we would call this a sort of lag measure problem, and that this was one of the kind of key factors that felt that added to this fragmentation and complexity and the challenge of trying to respond quickly and effectively to local need within a national priority, national context of priority setting. In common with many researchers, I've just gone straight to the problems. So I just want to note that there was a number of strengths that also came through within the research. We saw progress was being made on particular aspects of ethical commissioning, particularly around person-led and human rights approaches. There was a lot of work being done about full involvement of people with lived and living experience. Most people described this as imperfect, but also felt that substantial progress has been made. And there was an overall commitment across the system to the idea that better was possible and a commitment to the idea of recovery and people living good and full lives in whatever personalised way was possible for them to do so. So it was not a system without strengths, but it was a system characterised by people making their best efforts against a set of structures that could be optimised to make those actions easier to do. Fragilities in the system, we saw progress being constrained by The usual issues around public service just now, but these were felt very acutely within ADPs. So that was sufficiency of funding and its mismatch with the kind of level of demand and the types of demand in the area. The challenges of truly outcomes-focused practice and the balance between outcomes-focused practice and the need for quality and other metrics within the system, and a general sense of fragmentation of funding and the desire and attempts for people locally to take those fragmented drivers together, knit them into something holistic locally, and deliver that as a kind of constraining factor within the system. So I'm just going to touch on 3 themes from the case studies, and this is really just to illustrate a bit of the breadth of what individual areas we're facing and looking at and their responses to it ahead of hearing from people currently in practice. So this is just a quote from one of the case studies. Apologies for the on-the-nose illustration. I just thought this was a really beautiful photo. My part is literally to bring the threads together, to get the right people around the table and weave them together. So this was a really lovely illustration from one of our respondents of a theme across everybody we talked to, which was the role and necessity for adaptive and systems leadership within the ADP context. And that this then filtered through into how these ADP coordinators saw themselves as commissioners. They most commonly would describe themselves as what I would call a systemic commissioner. So they took a whole systems approach and attempt to broker consensus, negotiation, and agreement around a table. And the kind of common analogies and pictures were about weaving, sitting together, that patient development of good working relationships, driving service choices in an area. So this theme saw embracing the ambiguous position of the ADP coordinator in particular, owning it and saying, I may not have positional authority, but I have substantial systemic authority, and this is how I'm going to deploy it, by bringing people together, by convening, and by bringing the threads together. And to support this, the focus on transparency and honesty, the need to balance the different voices around the table, with the clinical voice very much coming to the fore in all of these settings, and how best to manage that, given that people are complex and their lives are complex, and there is a substantial clinical component, but it's not the only part of people's lives, and how you can have effective conversations when interventions are contested and resources are very constrained. And the other recurring aspect, the other recurring theme underneath this was the attention to foundations. So a lot of attention to relational aspects, working between the partners, is seen as a very important part of the work, and an important part of development, evaluation, and commissioning. And this would reflect the broader findings from the work of IRIS more broadly, where we see really for effective systems change, you're looking at 0 to 3 years. It really needs to be spent building those foundational relationships for effective collaboration before you start seeing broader change in a system. So moving on to a second theme, there was a clear tension within all of the case studies and the broader findings between whether we keep trying to fix a failing system, as identified by this, again, very interesting and kind of cogent quote here, or whether it's a system that needs a fundamental reset. And in common again, I think, with a lot of public service challenges, the people who work in this, all of us in this room, long for a radical reset, but pragmatically recognise that the system as it is what we've got, and how do we make the best of it just now. So that plays out across all of the research. So in this again was looking at a visibility and shared understanding between partners as to what the system was, what the resources actually were, not what we wished them to be, and how we could make better use of that knowledge within local settings. A number of people identified an interest in, and this sort of initial conversations around a radical systems reset. So this would be, for example, making the third sector the primary provider of ADP services in an area, with statutory services providing a minority of that support. This would be a very big shift in the system, and therefore was quite people who spoke about this felt this was quite constrained and quite difficult to get over the line, but it was an illustration of how there was dissatisfaction about operating in a system they felt they were trying to hold together that was becoming very threadbare versus a radical reset. You'll be glad to hear I'm nearly there. So case study 3, we've gone again thematically into, again, a yet more radical conceptualization of both the ADP coordinator role and the role of commissioning within that. And I thought this was a really profound quote from one of our conversations. In a very concrete way, the people whose lives we're trying to improve and whose outcomes we're trying to improve are all the time being disenfranchised and marginalized and mistreated by what's represented on the planning partnership. So this type of ADP commissioner, I think, could be described as radical. So this theme was really seeing the role of the commissioner as supporting, empowering people with lived and living experience to radically shift the balance of power within ADP partnerships and within the provision of support in this area as a whole. Those who spoke about this were very pragmatic about how far it could go, but they very much demonstrated walking that tension between knowing the system was beginning to damage some of the people they supported, living with that and holding it, and still hoping for better. And again, a very difficult position for ADP coordinators in particular, but people across the system to be placed in. The other aspect of this theme was really seeing the partnership as part of the bigger system. And again, this is something we say a lot in our sector, but there was a very practical and also a kind of conceptual reason for this within the respondents who talked to this issue. So the system beyond ADP provision was seen as absolutely critical to people's ability to use services on a practical level. So again, these will be familiar to everyone on this call. Difficulties with the broader system, with universal services, with access to basic health, with access to transport were major predictors of how much people could engage with the supports being offered on behalf of the partnership. And a more kind of profound or conceptual view was also described. So there was both the practical and the kind of values-driven or ethics-driven aspect, where people described the absence of hope within communities, the absence of hope within the people they were working with, and that sense that of very much of, as Mark Smith would put it, the need to help people find somewhere to live, something to do, and something to love, as well as have clinical and other interventions helping them to deal with their relationship between them and drugs and alcohol. So the big question that, there we are. The big question that came out for us in the research was actually, is ethical commissioning possible in ADPs, given the constraints on the system, given the competing drivers, given the kind of real difficulties that we found people were facing across the system? But common across all respondents was a commitment to making things better for people. Again, it's a glib thing to say, but it is quite something in the current operating context that people still hold that spark of hope, and I think we should celebrate it. They coupled that with a very clear-eyed understanding of the limitations of the operating context and what could and couldn't be done, and a very pragmatic attempt at broadly ethical practice. So it may not have been thought of or conceptualized as the principles were set out before, but it was a broadly ethical practice in commissioning and the application of the principles as a whole. So the idea of doing good through commissioning was there, although it might not have been conceptualized exactly as we articulate it in the principles. There was a real understanding of the limitations of the underpinning structures, the insufficient or fragmented resourcing, competing priorities and ambiguous power position. But again, a recognition that in some of those there was some flexibilities, and in embracing and understanding the system as it was, they could make change happen. But fundamentally and overall, they identified that a fully ethical approach to commissioning could not be delivered within this sector without a radical change as to how ADPs function. Of which more in my last slide. So the recommendations from this piece of research range from the individual to the systemic, and they come out of our conversations with respondents. So it was felt that individual ADP coordinators and ADPs as a whole might benefit from a little bit of support and guidance around commissioning. Commissioning was not seen really or conceptualized really as a major priority, although people were actually doing it. It may just be the way people think and talk about services in this sector is slightly different. So we did recommend that perhaps a bit of just enough guidance, we don't need any more cascades of it, but a little bit more about commissioning and how it's a useful lever for service planning might be useful in this area. Some work on what a shared understanding of what ethical commissioning would look like practically in this sector, and perhaps a bit of support around that for areas who wished to pursue it. In the kind of more structural or systemic domain of funding and prioritisation, we found that an exploration of place-based and human rights-based budgeting would be something that would be worth exploring for the whole system. So this would be removing the directive nature of current funding structures and ADPs and actually saying, how do we do this on a place-based level across the systems, linking well with external aspects such as transport and universal services to get a more holistic experience for people requiring support in their area. That's quite a radical recommendation. So were that not to be possible, co-producing those goals, co-producing those directives and co-producing those priorities between local and national partners, between politicians and between civil servants to make sure those directives were aligned with what was being seen on the ground and were flexible enough to allow redeployment of resources according to local needs. Or maybe an overall review of expenditure effectiveness across the system. So looking at, is this structure working for us? Are we resourcing the right areas while recognising that the overall funding envelope is unlikely to shift? And our final cluster of recommendations looked at learning and data. And again, these are sort of systemic, and again, they're shared across all partners in the system. So this was very much to say, can we move from a target-driven approach, not saying there should be no targets, but an approach that's actually a learning-orientated system. So this goes back to one of the findings we had about this lag in data and this lag in information, that if we as a system were seeking learning, that feedback loop would be much shorter and priorities from the centre would be more aligned with what's been seen locally. Again, this is a sort of medium term I would describe as a reasonably radical reset, but again, it's not out with it's not out with respondents' ability to deliver, given their relational focus in their work more generally, and the fact that it is very partnership driven already, is very multi-stakeholder driven already. So those give you good foundations for moving your orientation from targets to learning. And that was a very, very quick summary. I'm sure people will have questions and there'll be stuff I have missed. I'm just going to put a couple of contacts up before I close and hand back to Des for the Q&A. Louise Bowen was our lead on this, so if you drop her an email if you have any questions, and I'll shortly be leaving IRIS, so I've just put the contact for the interim CEO up on this slide, so you're able to get in touch with him if you have any follow-up, and I happen to have moved on to my next role at that stage. So I hope that was of interest. Someone has taken control of the presentation, so I'm going to put myself on mute and hand back to you, Des. Is that right?
Spot on. Thank you very much, Dee. And really comprehensive coverage there of what is an even more comprehensive report. So being able to summarise that down and to make it really meaningful for people has been great. Thank you so much. I'm minded of time because we started just a little late, allowing people to come in, and there's not been any questions come up in the chat yet. So what I was going to suggest is that we just hold questions to the end of the next session. Please do start putting questions in the chat during that, the next three inputs, because it gives us something then to work on to feed in. We've not had microphones activated, just quite simply when we've got larger numbers, it's usually easier to do that. And we might be able to find a way of doing that if people want to come in. If you want to raise your hand in the Q&A later on, we might be able to unmute and individually and allow people to come in as well. So we'll try and do that if we can. One of the points there that Dee made was about that kind of interconnection between local and national. and about, especially when it comes to prioritisation, and we know that a lot of the agenda for around drug and alcohol services is set nationally, and what was being heard there was just how important it is to make sure that there is more of an alignment with the broader spectrum of, you know, self-directed support, people having choice and control, empowered communities, and that actually there should be more of that direction coming from local, and that some kind of matching together of that. So what you're going to hear from is three local areas. You've heard that national kind of picture drawn together there. It is based on local learning. That's what we asked Dee and colleagues to look at, is what's happening out there in the real world. So we're going to hear from Farid, John and Michelle. And the questions that we asked them to kind of reflect on was, what did they see as both the challenges and, you know, the opportunities, how commissioning might look better in relation to commissioning to support people with complex needs who use drug and alcohol services. So that's what we were asking them to reflect on, about the challenges and the opportunities. So we're first of all going to hear from Barrett Hopkins, who's the lead officer, as I said, from Protecting People team in Dundee City. And then we'll move on after that. So Farid, would you like to be able to come in and just share some of your experience and learning? Thank you.
Thank you very much. And thank you, Dee, for an excellent presentation. Although Dundee was not part of the areas that contributed to the research, so much of what was covered in Dee's presentation makes a lot of sense to me and is very relevant for Dundee, including the recommendations. I've only got a few minutes to answer the kind of two questions, but just very quickly, by way of a context, I am the lead officer supporting the ADP in Dundee. I very much consider myself as a commissioner. In Dundee, the ADP takes commissioning very seriously. We have a strategic commissioning plan that we've made public. It's available on our website. We have the ADP set up a commissioning group that is working for the ADP, and the chair of that commissioning group is the Health and Social Care Chief Finance Officer, and we have a governance structure, and we are supported by the contracts team to monitor and the funding decisions that we make. Because as was discussed earlier, commissioning is a kind of circular process that involves a whole range of moves. So we've got a whole kind of structure, and I'm very happy, if that's of interest to anybody, to share more of that. So I was asked to talk about the main challenges, and the challenges are in supporting people with complex needs who use drugs and alcohol. So it's not about the commissioning services, and there is a slightly difference. And first and foremost, at the moment, one of the biggest challenges that we have, and again, just to clarify, I'm going to talk about the specific, relatively small ring fencing drugs and alcohol funding that ADP receives through either health and social care partnerships or NHS boards. ADPs receive to support individuals in their local areas. So it's a reasonably small amount of funding. It's a very complex picture of funding that we receive from the Scottish Government, and it comes with a lot of instructions of how it should be allocated locally. So within that context, that is what I'm going to talk about. So one of our main challenges at the moment is that with the general squeeze on public funding and social care funding, the ability of the ADPs in Dundee, the ADP in Dundee, to plug small holes to support people with very kind of highly specialized and specific needs that they have around their substance use is becoming less effective. Because if you think the people that we work with, they're affected by poverty, they're affected by the lack of ability to access primary care. They often really struggle to access mental health support for their children. Very often we don't really have family focused services. So the support that comes from the ADP, which is kind of highly specialized and reasonably modest is less effective in this wider context where people are struggling to access other services that they require. So that's one of our challenges at the moment. The other challenge is that by and large in Dundee, most of the funding we have is already allocated, it's already spoken for. But the nature of need change and good commissioning, and in a minute I'll make some points about that, but good commissioning needs to be very kind of agile commissioning. You need to be able to respond to need, and the need does change, prevalence change, the kind of drugs that people use change, and our ability to shift funding to support that is limited. It is a challenging thing at the moment for us to do. I think we've got some examples of that, and in the minute I'll talk about it. But I think that's one of the kind of key requirement, and that's a real challenge for us. And the last point that I'll make by way of key challenges is that the budgets that we receive from the Scottish Government, most of them we don't know from one year to another what will be the size of that budget. So planning for the long term is very difficult for us. And it's difficult for the organizations that we support. And increasingly that is becoming more and more of a challenge because we rely more on the ADP funding to make sure that people have even the kind of the very basic needs that they have. In terms of the second question, because I'm just aware of the time, in terms of the second question, so I'm nearly out of time, so I'll just say, if we were to start, what is good commissioning, we wouldn't start here if we were to start with good commissioning. And as I've already said, good commissioning is one that can respond and continue to respond to changing needs. So, you know, a lot of our services and our commissioning is directed towards heroin use rather than non-opiate drugs or alcohol even. Very often it focuses on the needs of men rather than the needs of women. It is focused on crisis management rather than prevention. And what we need to do is shift a lot more resources to work in a trauma-informed work. In Dundee, we know that we need a lot more focus on independent advocacy and a clear gendered approach. So I can see that Des is coming in, so that's probably my time is up. I'm very happy to answer the questions later on or to provide more information about what we do in Dundee if that's of interest for anybody.
Thanks so much, Vered. And it is one of those things is that I'm sure there is a lot more in there, and there's certainly a couple of questions that come to my mind. So it'd be good to pick them up with you in the Q&A session. Thank you so much. So we're going to hear now from John Holland, who's the strategic lead at North Lanarkshire, and again, just giving you a little bit of an insight as to what's been happening in North Lanarkshire area in relation to this work. So, John, are you there?
I am. Thanks very much, Des, and thanks, Dee and Vered, for the input so far. I suppose when I was thinking about the questions that were posed around the current challenges and what would make things better in terms of commissioning, there's two big questions to answer in such a short space of time. So I thought what I would do is talk about what we've been doing in North Lanarkshire. So our strategic aim, if you like, as a partnership was to focus on quality, choice and connection and a no wrong door approach for people who use alcohol and other drugs and those around them. And I suppose when we think about the money that comes direct through ADPs to support the additionality alongside statutory treatment and support services, what we've been working on is our governance and structures in order to make the decisions about what we invest in and where and how we understand what impact that has. So a lot of the work that we've been doing over the last 3 years is creating the space and time to discuss the short, medium and longer term priorities, looking at local evidence and needs, and then thinking about how we target those responses, which helps us then form the tender spec, if you like, that then goes through the procurement process. And we do that through our 5 thematic subgroups within the ADP that's then signed off at a board and finance level. A lot of that is formed around listening to what people need, those with lived and living experience, and the experience and insight of the workforce that are there to support people in order to try and build that improvements, even if the priorities change over kind of policy shifts and funding shifts. It's been important to us to have good representation across the ADP who have the insight but also the influence to cut across other priority areas. Again, we understand that people who use alcohol and other drugs and have complex needs may be coming into contact with our system in a variety of services and points within the community. So a recent example of us commissioning was last year. We were hearing through a rapid review of services and supports from people who work in services, those who use them, and family members, that there was a need for crisis outreach, assertive outreach responses, extended hours, and also links to housing. And at the same time, our housing colleagues who sit on the ADP and are represented there had monies left over from rapid rehousing transition monies, but not enough to tender a whole service. So we built that into the bid, put it out to tender, and now that service was launched last year and is delivering across North Lanarkshire to meet the needs of those who are presenting as a result of a near fatal overdose or those who are presenting in crisis through housing. One of the other decisions that we made as a partnership based on feedback from our services and stakeholders was our commissioning cycle, and to look at how long services are commissioned for. So any new services will move to a 3+1+1 year cycle, just to offer the time and space for staff to deliver quality in their services, to retain good staff, to help build up the relationships that are required to support people at the earliest opportunity around their alcohol and other drug use. In terms of what good or better commissioning might look like for North Lanarkshire, it's certainly focusing on people and relationships, both between individuals and the services they need, those around that individual, including their families, and also those working across services. We also need to think about how we meet the needs of people holistically and the needs of those around them, and understanding that we need to retain good staff, and also looking at the most appropriate skills mix across both treatment and statutory services and within the community, so that everybody's needs can be met where they present. In terms of the challenges, it's already been touched upon in relation to data, but what we can do is use some of the commissioning processes to look at shared intelligence and build that into service level agreements. There's also wider financial implications that have been touched on here in terms of cost of living, economic factors that affect individuals, and the wider workforce that we need to think about as commissioners, but that goes beyond the ADP. And again, thinking about our own relationships across the partnership. I think that's pretty much the key focus for the ADP. I hope that's been helpful in trying to understand what we're doing in North Lanarkshire and how this fits. And I'm happy to answer any questions, or if people want to make contact, reach out.
Fantastic, John. Really concise. Really appreciate that. It gives you a good flavour of that range of works that you're doing there. So it'd be and I'd certainly see questions coming in. So maybe pick them up in the Q&A in a wee minute, if that's okay. Thanks very much, John. And we're now going to hear from Michelle Duncan, who's the Strategic Planning Manager at Clacks and Stirling. And hopefully you're there as well, Michelle. So the only thing about having lots of people on the call, you can't see everybody in the one screen. So I'm hoping, Michelle, you're there.
I'm here. Hi.
Hi,
Hi, everyone. So I'm Strategic Planning Manager. I'm not directly involved in the ADP, but I've been, my colleague Simon Jones was unable to attend, so he's clued me up in everything, and I have kind of had a lot of kind of experience and conversations with them as well. So in terms of the challenges, obviously there's a huge number of challenges, and Vered and John have described those, and Des in the presentation earlier as well. I think the focus on complex needs of alcohol and drugs is really good. It's not just alcohol and drugs, it's the mental health, employability, housing and everything is something that needs to be considered, and pointing to the person-centred approach based on their rights and situation really needs to be included. we found that often people's rights are poorly described or acknowledged, and certain services not recognised either. So there's a real need for culture change. And also many people aren't aware of their rights or aware that they're entitled to support. So we've worked with Reach Advocacy to train staff and members of the recovery groups on rights as well. And linking human rights to our services is one of the priorities within our 10-year strategic commissioning plan. I think it's really necessary to understand the structural barriers that are imposed around the commissioning practice as well. So in terms of what good commissioning looks like, and for us in Clacks and Stirling, again, human rights and equalities are at the basis of our commissioning. And we're also kind of really into the commission cycle of Plan, Do, Study, Act and Review as well. So we're currently implementing our commissioning consortium approach, but currently we're in year 3 or 4 of that as well. And the ADP consortium is well established. It's got a varied memberships, including HSCP services, third sector organisations that are operating in the area, and key to this, lived experience membership as well. It's maybe not as far along as we would have hoped it'd be, but it's a really lengthy process. Relationships are being built. We're kind of getting more use of data, qualitative and quantitative, and building trust in the process too is taking a bit of time as well. So we're kind of at the point where I think collaboration approach has been established. As we've kind of talked about, human rights being embedded in the service design and delivery, so using the kind of panel and AAAQ principles as well of participation, accountability, non-discrimination, equality, empowerment and legislation, and also for the AAAQ, availability, accessibility, acceptability and quality. So they're key elements that we are looking to review services and design services by, and they're put into the commissioning of things as well. I feel like we can't really emphasise the importance of lived experience being involved in the commissioning process, understanding the complexity, the stigma that they're experiencing, how that's connected into individuals' identity, and how this can push people into greater risk. So on that, not only are we focused on services that help with prevention and early intervention, but harm reduction is a significant focus in the Clacks and Stirling commissioning too. We are really keen to understand what matters to people, so developing more choice and control options as well. So I think Dee was talking about in terms of contested interventions amongst practitioners, this really helps as well, that we've got people in the room that are able to share their experiences, and that's also people that have lived with substance use, and also the people on the front line as well. But on the other side of that, we need to make sure that that lived experience and involvement is meaningful and it's proportionate as well. The inclusion of lived experience to share their experiences, we need to have a trauma-informed approach as well. But it's also kind of the payoff that would then help improve service delivery and foreign policy too. So again, building the trust and good relationships as on top of that, the people need to see real action happening as well, which can be slow. So there's that kind of really good communications, managing expectations, and it's also an open conversation about resources and where money is spent and how we need to change things as well. On changing things, there's a real need for a power rebalance around the room when commissioning. So we've had learning that we've gained working with the Resilience Learning Partnership, and by that we mean the focus on lived experience from frontline staff and organisations leading the commissioning process, rather than a single commissioner or kind of statutory services as well. So we're moving away from the medical model. It's not always appropriate for the complexity that we're trying to support, and we're reordering the system of care too, away from traditional thinking and working. Service delivery needs to be more integrated throughout all services within HSCPs, and strategic planners are kind of leading that aspect as well. So to recap, for us, good commissioning really needs to be focused around a human rights-based approach, lived experience, and rebalancing power around commissioning too. I hope that was within time. Thanks very much.
It was perfectly within time. Thank you so much, Michelle. It was brilliant. And again, really, what's been good is hearing different aspects of work in areas as well. So there's been themes that have cut across all of you, but there's also elements that you've drawn out separately. So we'll just do a bit of Q&A just now. So there's certainly been some questions come in the chat, and I've just kind of noticed some reflections on the points people were making. And I guess the kind of three elements that maybe picking up with speakers, hopefully they will all come on screen. So the idea we'll have all the speakers to come on screen just now, and you'll be able to see. To cover areas, I guess the key one was about flexibility and stability, being able to get that balance between flexibility and stability. The issue around about local and national direction, where we're drawing our strategic direction from, and that element that was mentioned in the last one in particular around about lived experience. So in terms of flexibility, Dee, can I maybe just kind of come back to you first, having done the overarching research, had you any reflections about, I don't know if there's a sweet spot, but what's that, the notion of things like length of contract, having the flexibility, but also being able to give stability to organisations. Some of what was mentioned by one of the speakers around place-based, that thing around about giving, I know in fact it was yourself talking about what place-based might look like, so that actually allows areas to identify their own priorities, which takes us into the second question, but really just in the first point about flexibility versus stability. Any thoughts on that, any reflections?
It's an interesting one to pick up, because it's a recurring theme across this piece of research and actually broader IRIS work, and anybody here who's third sector who's just read the pre-budget scrutiny report, it's actually about this question. And I think I don't underestimate the challenges for anybody in the system on this, but one of the things that did occur to me is that we do have means open to us to plan on a 3-year basis and place break clauses in where required for renegotiation of pricing, or indeed for closure of contracts. So there's something about, there are means open to us to say broadly, with the best will and intent in the world, our commitment is to 3 to 5 to 10 years even, but we have to protect ourselves contractually. And I think most of us across the system would understand that, because that's our operating context too. That's IRIS's operating context year to year. Probably everyone on this call is very similar. Would that give us enough stability? Probably not, but it would give us a sense, maybe enough to kind of try and see to 3, 5 and 10 years. But I think I'm stepping a little bit away from the research into my background as a commissioning specialist. So take that with a pinch of salt.
That's why I picked on you first, because I knew you could do both. You knew that though. Vered, I was going to come to you anyway, so that's brilliant. Do you want to come in and just pick up on that theme? Thanks.
Thank you very much. Just to say that I think it is also possible, given that we work locally with third sector organizations, we develop very close partnership relationship with them. To change what we need to do doesn't necessarily mean we need to take the funding from them. We can ask them to do different things. And I think third sector organizations are incredibly agile, and their ability to shift and relearn and refocus and work in different ways, I think is really impressive. I wish that perhaps in the public sector we were half as good as doing that. So I think it is possible to change. It is possible to have much more agile kind of responsive commissioning, but not necessarily remove funding from organizations that we have developed local partnerships with. Thank you.
Thanks, Verdon. I mean, again, I'll draw on my own experience, knowing that kind of there are models of commissioning which are much more looking at the theme over a 10-year alliance kind of model of contract, where there is much more flexibility, as you say, to respond to changing needs, and no area more so than in drug and alcohol services, where that can change dramatically. John, Michelle, was there anything that you would want to come in on those? John, did you want to come in as well on that one?
Yeah, it's just to agree with Vered. I think that the steer that we have from the Scottish Government in relation to the national missions on drugs and what in theory we should and could be doing it is set out very clearly. I suppose the conversation that we have across the partnership is how we do that and meet local needs, and that's the flexibility that the third sector or community voluntary sector organisations are really supportive of, on the basis that we use or tend to use those organisations that have core contracts with us, and then other pieces of work we look at quality improvement methodology and test of change approaches where we put small amounts to test something, and if it's scalable then we'll take that back and reflect on it. So yeah, it's mostly just to kind of agree that there are some limitations to what we can do in terms of that whole systems change, but we are trying to do what we can with the limited resource and the responsive services that are linked to our partnerships, helping us do that.
Thanks. And Michelle, I'm just mindful that you talked about having that collaborative that you've established. Is that part of what you're aiming for within that, is to get that balance of flexibility and stability in that model?
Yeah, and I think the kind of regular commissioning consortium meetings is looking at where there are gaps and where there can be changes, and like Barrett and John have explained, that kind of agility of the third sector to pick up where there's gaps, there is that kind of flexibility. So it's kind of really collaborative.
And to bring in the next theme about kind of local and national, Vered, I think it was yourself that was talking about that thing about that it's relatively small amounts of money that are coming through the ADP route, and they are, I think, I don't know if you quite said prescriptive and descriptive, but something of that ilk, that that you're given clear steer from above. I wonder if there's anything you've got reflections about. What would happen if you were giving more flexibility even in those small pots of money? Do you think that would be something that would help? I wonder if you'd come in on that.
Thanks. I think it will help. I think we know very well. I think we do locally know very well what our local needs are. I think we know who the kind of main organizations are. I think we do have quite a lot of experience, not just for the ADP. I mean, for ADPs, we work in partnership with a lot of local organizations and support from the Health and Social Care Partnership, from public health locally. So we know what the needs are. We know where there is funding will be most effective. And I think if we just received a budget and we knew that budget will be recurring each year without, I mean, I think anybody who looked at a spreadsheet that sits with ADP's financial spreadsheet will understand the complexity of the funding of this relatively small fund, and that doesn't help. So if we could have the one fund, we will know the length of time that we are able to have that fund. That will allow us to do a lot more local planning and be more effective, definitely.
And John, just following on from that, there is that thing about other monies that come into local authorities and to IGBs around about, for example, mental health services. So that blending in with wider range of services, is that something that you're very much, I don't know what extent are you able to control that? I mean that in a kind of a directive and an influencing way. Is that something that you already look to, or is that something that could be better if those were aligned, if the budgets were aligned better?
Yeah, I mean, I'm kind of talking from the ADP side of things in relation to the kind of priorities that we've got that Vered's already highlighted. So I suppose the way that we look at those allocations is additionality to those baseline budgets that are coming through, like NHS or health and social care partnerships. And there is some flexibility. And with some of the recent activity, it's looking at, well, how can we combine some of those monies to look at a more holistic and joined up approach, for example, with the crisis outreach team, and also, for example, with looking at advocacy for, again, mental health and disabilities and the MAT standards. So we've done that as a collective bid with individual lots, which making best use of that money, but maybe making some savings and actually targeting those savings towards direct community supports and actually interventions rather than it going on other costs. So there is some crossover, but there's still lots more work to do. But then what happens at the end of the national missions and what is the next funding source, is that going to be continued? There's still some uncertainties around that, which means that whatever we embark on, there's caution about, are we overcommitting to something that we don't know might be there later on? So there is some challenges around that.
Thanks, John. And I guess the other part of that is the kind of one of the things that Feely did in his report talk about collaboration rather than competition. And at the moment, when there are, especially when there's limited budgets, that notion of competition doesn't really ring very well at all for any of us involved in health and social care. And again, maybe Michelle, coming back to yourself, that are you finding that your approach of that kind of collective is allowing people? I think what I heard you say is you've spent a lot of the time building the relationships. And if you remember that slide that I put up earlier, one of the earlier iterations, and I think possibly a more useful one, is trust-based commissioning, and it's not a kind of throwaway trust, it's a genuine building confidence trust. I don't know if is that your experience of what you're building in CLACS?
Yeah, it is, and it has taken a long time. And I'm not directly involved in the ADP, but I know that there's been some difficulties in the dementia commissioning consortium, for example. A lot of people used to delivering certain services, but there's been gaps. So the commissioning consortium approach and having everybody around the table is really good to be able to say, right, where are the gaps? Where's their over delivery of services, and how do we divide that round? So we're now at the stage in the ADP and other like carers commissioning consortiums to get to that point where people are on board. There is that trust, there is that understanding that the budget's there, and how that's going to be, like, if we'll play to our strengths rather than the kind of competition, and where can people see opportunities to fill gaps as well. So but it is a long process, and managing that expectation as well is really key. So you really need to have really good communications with people as well.
That's good, but it's great to hear that that's difficult as it is, that there's beginning to get traction and people are beginning to feel more confident at that. Dee, I was going to come back to you just on your broader knowledge again, just because I know you can. The question that somebody asked earlier on was about that balance of things like open book finance. You know, if we're talking about collaboration and kind of working collectively, the notion of open book finance, being able to kind of understand people's drivers and that in a competitive tendering environment. And I don't know if you wanted to, if you felt comfortable to say something around that kind of balance about how, because again, it's about how to work collaboratively in the commissioning space rather than competitively. And I know that in your current role and your previous role, that was a lot of discussion about what does that look like. And I don't know if you've got any nuggets to share with people.
That was a nice, easy question. So, sorry, open book accounting particularly, or just the generally around?
More generally around it. The question was asked, cited things like open book. So, but that's very specific. More generally. Yeah,
no, it's a good question, and I think open book accounting is an interesting kind of illustrator of how transparent you could be in contracting. And I do think this is really challenging, and I've got one eye on the chat, which is always a bad habit, because people are making really interesting points here around the broader questions around sort of the dichotomy between competition and complacency and stability and being stuck with an unresponsive provider, you know, and these kind of very difficult tensions that sit across the system when we try and think about how we commission. And I guess there's a bunch of methods around this, and they're all codified in different ways, but really what they fundamentally are actually asking us to do as a system is to move, if you bear with me, from a sort of parent to child dichotomy, I have money and I tell you what to do, to an adult to adult conversation, which is, this is what I'm hearing from the people I'm supporting. I need to pick up the phone and talk to my commissioner about how we respond to this in an agile way. And I know that sounds like a bit of a cop-out, but I think if we framed these conversations that way, which is actually what we saw from the research, largely that was the kind of very collegiate kind of view people held within the local systems in particular, then we would circumvent some of these worries because we would name them. We'd get around the table and say, listen, you've been here for 10 years and you do great quality work, but I'm really worried you're getting complacent because you're doing this thing and it's not working for people. So there's kind of two things in there. adult to adult resetting of our relationships, and that probably applies across the whole of our sector, probably applies across the whole of human endeavour, let's be honest, but let's stick to ADPs just now. And also a reorientation of public service towards the person. I'm pretty sure everyone on this call came into this business to make things better for people, but we've got lost because of scarcity in the game, in the how do I squeeze a bit more out of this? How do I knit this funding together? How do I deal with all this overwhelming demand? So I think if we were able to kind of do those two, which are kind of relational tasks, well together, then we would find the technical ways around it. And now I am well and truly on my soapbox, so I'm going to press mute, Des, and pass back to you.
I did offer you a soapbox to stand on, so that's fair. There is a lot coming in, and we have got limited time, but the one bit I would like to come back to is the lived experience, because I think there's something that I remember one of the first pieces of verbal feedback from Dee when she was having conversations, or when colleagues were having conversations, was at the point of what are we talking about when we're talking about the ethics here? Is this the ethics of what we're trying to achieve with the services, or is this ethical commissioning, as in the practice of commissioning, almost the more technical side of things? And there was something that struck me, Michelle, in your conversation about that lived, in fact, and everybody, how you genuinely have lived experience reflected in here, and being able to drive it. If we take that same approach of self-direct sport, what matters to you and what matters to individuals, probably of all areas, this is quite a difficult one to get that. And I just wondered, Michelle, you spoke about it quite a bit there, if you want to say a little bit more about the importance of that lived experience and how you're making sure that that's properly represented in shaping service design.
Yeah, I mean, it is really difficult because I suppose sometimes we feel like we're relying on the same voices a lot of the time as well. So it's not a perfect thing we've got just now. We are constantly looking at making sure that we've got people to have options and trying to recruit people as well, but also making sure that it's not too onerous a task on them as well. So it's a bit too complex, and I don't feel like I'm very eloquent in explaining how that is. I think Simon Jones would have been a lot better for that, but it is difficult. It's something we are kind of reviewing and thinking about all the time.
But the importance is there. Vered or John, did you want to come in on that part of it in terms of just lived experience?
Do you want to go, Vered, or so we're both jumping in at the same time there?
Yeah.
I suppose that the approach that we're going for is that living experience should have their own space, but also with the option and choice to be involved at any level throughout, rather than saying it's prescriptive. Because obviously, what we're mindful of is that there might not be forums that are helpful for people to feel listened to and heard, and it's just trying to get that balance. We have capacity within the ADP support team, and again we had to look at how we were resourced as a team to be able to look at our commissioning processes and deliver on the priorities that we've been given, and part of that was committing a resource to lived and living experience in both driving that work but also engaging in a range of different ways with the community, from surveys going to the communities through our commission services with separate forums. So we're trying and testing every opportunity to make sure we're not missing anyone out.
Brilliant. And Vered?
Just to say that I think good processes around lived experience for commissioning are no different from the good processes that we need generally for the ADP. I think we all understand that the whole decision making of ADPs really does need to include the voices of those with lived experience at every stage. And I totally get what Michelle was saying. It's really challenging. It is difficult because we still rely on big, long, fairly boring meetings that can be quite daunting for people, and it's not particularly what they want to do. So I think there is a requirement for us to be far more adventurous here, and we have put quite a big resource to our third sector to support that, and hopefully will progress.
Thanks, Vered, and thanks everybody. That's been great just to explore those topics, and I think probably the common theme is that this has actually been a very short amount of time to try and cover an enormous topic with a lot of complex elements to it. It's really about a journey begun. I think that the research has hopefully shone quite a strong light on a lot of aspects that we need to look at, and hopefully from the discussions there you can hear a lot of journeys well begun, but a lot of distance still to go. And I suspect that, well, that is the case across the whole country, and we're very mindful of that. So, you know, that this seeing today as part of, so where do we go next on this? You know, if that's what the research tells us, if that's what we're hearing from people in terms of direct experience and working out and directly with people, then what do we do next, and how do we start taking on some of those big tickets round about flexibility, around about local influence, lived experience, and making sure that they're there. So what we're going to do is just kind of close off with, we've got a poll to do, but just to say that this is a journey begun, and what we'd be keen is that if people are interested in following through between our team and our colleagues in the substance use services team, that we do have an eye to these issues. Like anybody else, we don't have huge amount of resources to throw at things, but we do have some, and we do have a particular role as a national organisation to be able to bring some of that together, a bit like the knit threading together that Dee had in one of her slides, and working alongside national colleagues like Aris, we're keen to see, so how do we collectively at local and national level come together to address some of these? They have been issues, and unfortunately, of course, within Scotland, we still sit in a very uncomfortable place with drug deaths and with a whole range of those challenges. So how do we take this forward? So we just want to do a wee poll as a checkout, and then to say that if people are looking to kind of follow up conversations, the email was there at the beginning. It's in the slides. Please do contact us. It's not an offer to be able to do lots of things, but it is saying what's most important and how might we coalesce around those. So the questions for the poll then, just to maybe kind of bookend what we asked at the beginning, what did people know at the beginning? Hopefully, and this session has really been about sharing information. It's not been a lot of space for discussion, and we knew that, but what we wanted to do was to give people information. So hopefully that's helped. And so that first question, to what extent do you feel the session today gave you new information or ideas? It may not be new, it may just have underpinned things you already knew, but just to get a sense of, has it given you something more in terms of an understanding of the current world of commissioning and services for people who require support around about drug and alcohol needs? And the next question being, to what extent did you find the information in today's session helpful to you and your organisation? Kind of builds on that. Is it new, but is it helpful? Does it build on, if it's not new, does it strengthen? Does it build on what you already know? And then the third one, to what extent are you planning on using some of this information in your work? So this is just to get a sense as, from our point of view, has this been useful? Has this been, it's an hour and a half of people's time. What's been great is to see that we've sat between 80 and 90 people the whole time. So people have stayed, which is usually a good sign. But we just want to get a sense of how useful this has been to yourselves, and to make that offer to say, how might we take this journey forward collectively? I'll just give a couple of seconds to complete that. And can I invite Dee, would you be okay just coming back in? I'd just be interested in any of your reflections. You carried out this research, as you said, you do have extensive knowledge, and it's part of the reason that we came to your organisation, is that you have extensive knowledge of commissioning more generally. I don't know if you get any closing thoughts on where the journey is in relation to, especially as you're about to leave this field. It'd be any parting thoughts as it may be.
That's a very risky invite, Des. The last 4 weeks, could you say anything? No, I just wanted to say something that did strike me from this sector was the real sense of commitment that was really encouraging, because I was really grateful to hear from colleagues laterally that it kind of broadly reflected what they saw as well. But this real difficulty, the sense of people working extremely hard in a system that's sometimes not working in the best way to support that, was really striking within the ADP context, and something I think that this context can maybe share that learning with broader social care commissioning, because it's a really important aspect of the work. So and also just to say thanks to everyone today and everyone who responded to our persistence making them come for interviews with us. We appreciated your input very much.
Thanks, Dee. And thanks to everybody joining today. Thanks to our speakers. And also just to give a note, these events are actually a lot more complex to run than they seem. Hopefully it's felt quite easy on the eye and easy on the ears to be part of. But just to say thanks to Ashley, Lindsay, and Kirsty for running this and being at the back and making sure that all of the slides run, etc., and the chat, etc. So huge thanks to them. And just also thanks to Claire Hammond, who actually from our end was the real person that made all of this research happen. She drove this from our end of things. So me being able to front this is huge thanks to Claire for making it happen. So those, just to note those contributions to all of this work, and look forward to, it definitely looks from the chat that people are keen to continue the conversation and think about where we might go next. So thank you to everybody for that as well, and enjoy what's left of the day. Well, it's still mid-afternoon, isn't it? So thank you, everyone. Sorry, Stephen, I don't know if you're, sorry, I don't know if that was put hand up or if it was a clap. So thanks, everybody, and take care. Thanks, bye.